Afternoon or good morning, everybody, depending on where you are. I'd like to thank you all for coming along today to this free event on the subject of contingent electric skin shock. This is a very important topic, and I'm certain we'll all benefit from the contributions of our speakers today. So before we begin, some housekeeping. If you want to claim your free CEUs, I will give you a keyword during the event. So remember to record that keyword if you would like to claim your CEUs. If you have any questions for the speakers, please put them into the Q&A box, and we will ask the speakers that put the questions to the speakers for you. Today's event will involve two parts. The first part will involve a presentation by Mike Milan, and Mike works at the Spring Harbour Hospital, and he's part of the International Association for the Scientific Study of Intellectual and Developmental Disabilities. Mike will give his presentation. We'll have some quick questions and answers from Mike. And after that, we're going to begin our panel discussion with Joy Johnson and Dave O'Regan. Mike and his colleagues at the IASSIDD have recently completed a review of the literature on contingent electric skin shock, and they've also issued a policy statement regarding its use. So without any further ado, I'm going to hand over to Mike, and Mike will introduce himself and then begin the presentation.
Thank you, Niall. Let me share my screen here if that is possible. Give me a sec. I think I'm having some difficulty sharing my screen.
Okay, let's see if we can get that sorted for you, Mike.
There we go. All right. So hello, everyone. My name is Mike Mullane. I'm a licensed psychologist in the United States, and as mentioned, at a place called Spring Harbour Hospital, which is located in the state of Maine. My clinical practice focuses on behavioral assessment and treatment for challenging behavior with individuals with intellectual and developmental disabilities. My predoctoral and postdoctoral training were in these areas as well. I'm appreciative of having the opportunity to be part of this panel today. I plan to talk with you all about contingent electric skin shock, which hereafter I'll just refer to as contingent electric shock for brevity's sake. Contingent electric shock has been a controversial procedure used as a treatment for challenged behavior with individuals with intellectual and developmental disabilities for some time. I'll discuss some of the research on this topic and detail why the procedure should no longer be used. And as mentioned, and I do need to disclose that I am the co-author of a literature review, Zarconi and colleagues, on contingent electric shock research that provided support for the International Association for the Scientific Study of Intellectual and Developmental Disabilities policy position statement opposing the use of the procedure. I support the conclusions of this review, and the information I will discuss here today will be the findings and conclusions of that review. And with that, we can kind of go through the review. But to start, it's important to detail what contingent electric shock is. The United States Food and Drug Administration defines it as noxious stimulation to a person's skin to reduce or stop a behavior. Contingent electric shock is applied after a behavior occurs and is intended to act as a punisher. Put another way, the procedure is creating a painful contingency. If behavior A happens, then painful electric stimulation will follow. And it's important to differentiate this from electroconvulsive therapy, which is commonly referred to as ECT. ECT is used to treat psychiatric disorders like depression. The patient is typically under anesthesia, and the procedure is not intended to be a punisher. So There are studies that have reported that contingent electric shock result in a reduction in challenging behavior, such as self-injurious behavior or aggressive behavior. When I say self-injurious behavior, I refer to behavior like head banging or other behavior that could result in tissue damage. And when I say aggressive behavior, I'm referring to behavior like hitting or kicking another person. The United States Food and Drug Administration, the FDA, noted that contingent electric shock may have an immediate interrupting effect on self-injurious behavior. And I do acknowledge that the FDA is specific to the United States. With this said, the FDA review of contingent electric shock, which was completed in 2014, provided a comprehensive overview of the research and is available online. Despite studies reporting that contingent electric shock reduces challenging behavior, there are significant limitations associated with the research that cast doubt on the effectiveness of and the justification for contingent electric shock as a treatment. Specifically associated with contingent electric shock research, there are a number of methodological concerns regarding the immediacy and durability of effectiveness, um, um, concerns regarding the immediacy and durability of the effectiveness, concerns regarding adverse and unwanted side effects, and ethical concerns. I'll discuss each of these briefly. So for some of the studies that reported contingent electric shock reduced challenging behavior, their results are lessened by critical limitations with their experimental methods. Take, for example, Duker and CESS, which is one group study conducted in 2000. These researchers reported contingent electric shock to be affected. They implemented contingent electric shock with 8 individuals and did not implement the procedure with an 8-person comparison group. All of these individuals were presenting with self-injurious behavior. Their dependent variable was not challenging behavior, but instead a rating score of the degree and duration of mechanical restraint. They reported that participants exposed to contingent electric shock required less mechanical restraint relative to the comparison group, and reported an 82% reduction in mechanical restraint across 8 years. This study has significant limitations. First, participants were not randomly assigned to the groups. Second, limited information was provided regarding supplemental treatment components, and it is unclear whether they were controlled for during the experiment. This makes it difficult to determine the impact of contingent electric shock alone. Last, this study did not directly measure self-injurious behavior, instead using a rating score of the degree and duration of mechanical restraint. We don't know the process of how mechanical restraint was implemented in this study and how it was fated, and thus it is unclear whether there was a direct relationship between levels of mechanical restraint and levels of self-injurious behavior, and how both of these were related to the implementation of contingent electric shock. And it's noteworthy that even with these limitations, this study was classified as being the highest quality publication on contingent electric shock that the FDA reviewed in 2014. Several of the contingent electric shock studies that utilize single case design fail to demonstrate experimental control. This means that it is unclear whether there was a direct relationship between contingent electric shock implementation and any change in challenging behavior. For example, Azrael and colleagues implemented contingent electric shock with 60 individuals, utilizing somewhat staggered implementation of the procedure across people. Their design amounted to a series of A/B designs and did not provide a consistent, repeated demonstration of an effect. Furthermore, the study did not report any data on inter-observer agreement nor procedural integrity. Another limitation already noted in discussing Duker and CESS on the previous slide is that multiple studies did not control for supplemental treatment components and included other treatments in combination with contingent electric shock. This further limits one's ability to determine the isolated effect of contingent electric shock. There were several single case studies that were reviewed in Zarconi and colleagues that did demonstrate experimental control. However, the number of participants is relatively small from this group, and this limits the external validity of those findings. There are inconsistent findings regarding the immediacy and durability of effectiveness. Some studies have reported that contingent electric shock immediately reduces challenging behavior after a few brief sessions. However, results from Israel and colleagues, the studies indicate that contingent electric shock reduces challenging behavior only after months of all-day implementation in some cases. The durability of effectiveness, or how long the procedure maintains low levels of challenging behavior, is not certain. Some studies indicate that the effects are durable across long periods of time, such as months, with consistent implementation, while other studies indicate that the procedure loses its effectiveness across time. Lastly, it is unclear whether contingent electric shock can be faded. Williams and colleagues in 1993 successfully faded out contingent electric shock. However, other studies observed that challenging behavior increased following withdrawal of the procedure. More often than not, researchers did not even attempt to fade contingent electric shock. It's unclear what the long-term plan was for these individuals in these studies. Multiple studies have reported adverse and unwanted side effects from contingent electric shock. These adverse and unwanted side effects were summarized in the United States FDA review from 2014. What has been reported includes anxiety, fear and avoidance of experimenter, substitution of other challenging behavior, burns and other tissue damage such as blisters, crying, pain or discomfort, shivering, amongst others. These were anecdotal reports, and the adverse and unwanted side effects were not systematically evaluated. Moreover, the short and long-term psychological effects of contingent electric shock were not evaluated. Our knowledge of the side effects of this procedure are incomplete because they were rarely systematically evaluated, but what information is available is extremely concerning. I want to shift to discuss the ethics of contingent electric shock and ethical practice. Ethical codes guide our clinical practice and our research. Here are two examples of such codes: the American Psychological Association Ethical Principles of Psychologists and Code of Conduct, what I must follow as a psychologist here in the United States, and the BACB Professional and Ethical Compliance Code. In general, ethical practice involves procedures that are likely to benefit an individual and also present the lowest risk of harm to that individual. One must weigh the risks and benefit of any procedure. Contingent electric shock involves harm. It involves physical pain and is associated with other risks as previously mentioned. Thus, one would hope that someone selecting this procedure would have used extreme caution in reaching that decision. The studies using contingent electric shock have justified its use by indicating that previous lower risk treatments such as differential reinforcement had failed. At face value, this seems to be the case. Of the 101 participants in the studies reviewed by Zarconi and colleagues, 75% were reported to have failed previous lower risk treatments. Those using contingent electric shock justified using their procedure on the assertion that nothing else had worked. This was their last option. This justification requires a more critical evaluation. These studies provided little to no data on these purported failed treatments. Of the 42% of the participants who had reportedly failed previous treatments, no treatment data was provided. Moreover, no study provided a baseline versus failed treatment comparison. Furthermore, little technical information was provided regarding these treatments. It leaves one to wonder whether alternative empirically supported treatments were adequately considered. And as an example, here is an excerpt from Duker and Say's, just to give a general sense of the level of technical information provided in some of these studies. So here it says all participants of the study had exposed to a wide range of treatments such as psychotropic agents, functional communication training, systematic and unsystematic restraint fading, differential reinforcement of other behaviors, and gentle teaching. So this is not detailed information, and it makes it difficult to evaluate these treatments. When we consider that the justification for contingent electric shock, a procedure with a high risk of harm, often relies on previous lower risk treatments failing, It is vital to consider the quality of those failed treatments. If those failed treatments were not of high quality, then using a procedure with a higher risk of harm, like contingent electric shock, would be less valid. In the last 30 years, we have developed functional assessment procedures that we can use to identify the function of challenging behavior. We have technologies to find out why challenging behavior is occurring. This allows for the design and implementation of function-based treatments that do not rely on aversive or restrictive techniques. It is important to consider whether the failed treatments reported in the contingent electric shock studies were based on high-quality functional assessment. Of the studies that we reviewed in Zarconi and colleagues, functional assessment was reported to have been conducted for 66.3% of the participants. However, detailed information regarding the functional assessment was provided for only 13.4% of participants, and the actual data was provided for only 1.5% of participants. From the information provided in some of these studies, it is difficult to determine the quality of the functional assessment conducted and thus the quality of the failed treatments implemented. It leaves one with the question, what was the quality of a behavioral treatment that was not based on a high quality functional assessment? This question in turn leads to another question, was there justification for using contingent electric shock? And this last question is made more disturbing when one considers whether it was for only dangerous challenging behavior that contingent electric shock was implemented. The answer to this question is unfortunately no in the case of Israel and colleagues. It is noted that participants in this study received contingent electric shock for non-dangerous behavior such as not listening to a request or for using a swear word. I'm sure all of us have not followed a request at some point in our lives. It may have been because we didn't hear the request, or maybe we didn't understand the request. I'm sure many of us have and will continue to swear at times. I don't think anyone should be exposed to painful electrical stimulation for saying a swear word or for not following every request immediately. And not to harp on this study, but it is worth noting that in this study, some of these participants had not engaged in aggression for multiple weeks prior to the implementation of contingent electric shock. Thus, one might assume that contingent electric shock was implemented for these minor, non-dangerous behaviors. I'd like to review another study that provided questionable justification for the use of contingent electric shock. Salvi and colleagues implemented contingent electric shock with a 3-year-old child to reduce head-directed self-injurious behavior. They reported a reduction in self-injurious behavior and even conducted one session at 60 days without the device, with low levels of challenging behavior. It was reported that the parent just gesturing towards her purse, where she used to keep the contingent electric shock device, was effective at stopping even topographically similar behaviors to the self-injurious behavior. Prior to implementing contingent electric shock, the authors reported that parents were advised to use systematic positive reinforcement of incompatible behavior and to minimize the positively reinforcing attributes of the parental response to self-injurious. Apparently, these were rejected by the parents because they were too emotionally and practically demanding to implement as much as needed, as reported by the researchers. The rationale for contingent electric shock was that it would be a low-cost treatment with respect to time and resources, that positive procedures would require too much resources, and that positive procedures might not be effective, which in turn might increase family stress. At the time of this study, there had been hundreds of published studies on functional analysis and various procedures to identify stimuli that might effectively compete with reinforcement for automatically maintained challenging behavior in the case that self-injurious behavior was maintained by automatic reinforcement in this study. We don't know that though, because the researchers did not complete a functional analysis nor a reinforcer assessment. They also did not provide detailed information regarding parent training regarding positive procedures. They did provide much more detailed information on how parents were trained to use contingent electric shock. What is the likelihood of a function or reinforcement-based treatment that was to be implemented by parents being effective without these components? I would think little. There are significant concerns associated with contingent electric shock. as a procedure, as well as the studies that have provided support for its use. We concluded in the review, Zarconi and colleagues, by recommending against the use of contingent electric shock. This conclusion is not only held by us. Based on their 2014 review, and given the risk of harm associated with contingent electric shock and the limitations associated with the research, the United States FDA implemented a ban on electrical stimulation devices for self-injurious behavior and aggressive behaviors in 2020. The FDA indicated that such procedures present an unreasonable and substantial risk of illness or injury that cannot be corrected or eliminated by labeling. It is not just in the United States that opposition to contingent electric shock exists. The review that I co-authored, Zarconi and colleagues, was completed to support the International Association for the Scientific Study of Intellectual and Developmental Disabilities policy statement opposing the use of contingent electric shock. The review and this policy statement assert that contingent electric shock violates the human and civil rights of people with intellectual and developmental disabilities. Moreover, the procedure likely violates Article 15 of the United Nations Convention on the Rights of Persons and Disabilities regarding freedom from torture or cruel, inhumane, or degrading treatment. Furthermore, it calls on this policy position calls on all their countries to ban the use of contingent electric shock and other organizations to support this position. So to sum things up, the risks associated with contingent electric shock outweigh any potential benefit. There has been inadequate justification provided for the use of such a high-risk procedure. As noted, it's unclear the type and quality of functional assessment and other treatment researchers implemented prior to contingent electric shock. There are methodological limitations associated with the research supporting its use that make it difficult to ascertain what the benefits are, particularly when one considers the insufficient evidence regarding long-term effectiveness and whether the procedure can be fated. To end, contingent electric shock should not be used. Thank you.
Great, thanks, Mike. That was a really comprehensive presentation, so thank you very much for that. We have some questions here for you. So one of the questions that we received was related to the use of it. The question was, there were a few infamous proponents of its use, it being contingent electric shock. How common is it, or did your review examine how commonly electric shock is used with people with challenging behavior?
So in terms of research, we did find in that review that there has been a decline in the research on contingent electric shock, which is positive. I think the last study that we examined was from 2012. So with respect to research, there has been a decline, which again is a positive step. Regarding the use and the prevalence of the use, it's difficult to determine. I will say that it is not common practice, at least here in the United States. It's not a common practice. It's pretty limited to where it's implemented.
Great. So we have another question here from Cormac. It is, in everyday practice, service users continue to be excluded by less restrictive services. Some of these services are presumably high quality ABA services that use contingent electric shock, accept these service users. So what do you think excluding services are doing? What needs to be done to improve the quality of less restrictive services so as to avoid excluding service users to more restrictive services? Yeah, sorry, that's several questions there, Cormac. So let's just see. So I guess I think what Cormac is getting at there is the services that use contingent electric shock. Why are these service users that are being sent there? Do we know why they are not going to high quality ABA services that do not use contingent contingent electric shock?
The reasons why, I'm hearing a bit of an echo. Oh, it's gone. I can't speak to the specific reasons why, certain individuals were sent to us certain places. I think to that, that's a good question. Why the alternative procedures, the positive procedures, might not be effective, and I think it's important to, as much as possible, advocate resources such that positive procedures can be effective and implemented. I'm not sure if that addressed the question.
I think it addresses as well as we can, because it seems to me that there's a lot of things that we just don't know about the use of contingent electric shock. I think in the review that you and your colleagues conducted, I think there was 3 countries that that were identified as using contingent electric shock, at least historically. But as the main information that we have seems to be, if I'm right, from the published studies, and unfortunately the published studies have limited information, but even those published studies are only the tip of the iceberg in terms of the use of these things and the use of these cases, and they're probably subject to some sort of publication bias. But it would be really interesting if somebody were to try to conduct some research into the reasons why people end up in institutions that use shock versus other high quality ABA providers that do not depend on the use of shock. Let me just see if there, yes. So Aoife has submitted a question here. She says, thanks for the presentation. Is there evidence that comorbid mental health diagnosis or symptoms are related to the use or frequency of contingent electric shock?
That's a good question. So is the question asking whether the procedure results in any long-term adverse psychological effects? Would that? So that's the problem, is these were not the focus of evaluation in these studies. So it's another area where we simply don't know. Many of the adverse and unwanted side effects were just anecdotal reports because they were not systematically evaluated.
Yep. And that, I suppose, our last couple of answers there, Mike, are related to Kelly's question, which is, what are the possible reasons for the lower incidence of research in contingent electric shock? Do you think it's that more places have discouraged its use, or do you think it's more because of IRB restrictions?
That's difficult to answer. I think that there has been legislative action, the US FDA banning the procedure, for example, most recently. I think movements within the fields of behavior analysis and psychology moving more towards a function-based emphasis, a more reinforcement-based emphasis, a more positive behavioral support emphasis, I would suspect might be related, particularly since those procedures, we have lots of evidence that those procedures can be and are effective.
Yeah. Yep. Okay, so I think now is probably a good time to move on to our panel discussion. So I am going to just introduce our 2 panelists, our 2 new panelists here who will be joining Mike. So first up is Joy. Joy is a BCBA and an inclusion specialist and autism advocate. Joy, can you tell us a little bit about yourself and your interests?
So I'm a BCBA. I became a BCBA because I went through ABA as a child, and I wanted to help to tackle the problems that I saw with ABA. While I did experience some of the benefits, I experienced a lot of trauma. And so I wanted to get into the field to help remove the trauma that I experienced as a child in ABA. Took me a while to get here because I was certificate track. I was non-vocal until I was 12. My IQ was deemed to be under 70. So I didn't get a GED until I was 26. I have a lot of comorbid disorders. So my education was slow, but I finally made it.
Congratulations on that. And our other panel member is Dave O'Regan. And Dave, as his name might suggest, is an Irish board certified behaviour analyst and an advocate who works in terms of positive behaviour support in particular. Dave, can you tell us a little bit about yourself, your work and your interests?
Yes, so I would have gotten involved in this area, this line of work in the first place from having a family member with an intellectual disability and having an interest from a personal perspective, I suppose. But my original master's qualification had a heavy emphasis in positive behaviour support, and over the last 15 years, the different environments that I've worked in have generally been leaned towards support for people with significant behaviours of challenge, significant levels of self-injury and aggression, those types of things. So, yeah, there you go.
Great. Well, Dave and Joy, first of all, before we ask you any specific questions, have you any general reactions to the research that Mike has just presented? Have you any general thoughts that you actually want to share with us before we go into specific questions? And just a quick reminder to attendees that they can put any questions into the chat if they want to. Sorry, Joy, you were going to say
was the quality. He kept saying the quality of the alternative or the previous interventions. I think that the function, of course, is something that we focus on, but when it's sensory, when it's automatic, a lot of times people don't go the step further into considering that you have to find a match sensory input. It can't just be like occupied hands or something that like you really have to go into finding something that's match sensory. And I really find it difficult to hear that rather than helping somebody find a replacement behavior to help them regulate, that you would punish them or hurt them. Like we're trying to help them not hurt themselves, but it makes it better that we hurt them instead of them hurting themselves. That just doesn't sit well with me. And while I don't have any, evidence for this, what one of the questions about, does it lead to comorbid disorders? You can directly see in my medical records a year after I went through a study undergoing that I got diagnosed with depression, and I was a teenager. And I remember it, so I think that it had I was going through a lot of confusion. And of course, as BCBAs, we don't consider a lot of the internal events, so that wasn't documented on the ABA side, but I was really confused. I didn't really know what they wanted me to do, why I was being punished in this way, so I don't know, I guess it's very just difficult to hear because I still don't understand the rationale for it.
Yeah, that makes sense. Dave?
Yeah, I think like I was just chatting to Mike before we came on the call that the paper itself is really almost dispassionate and very measured and very balanced in terms of evaluating the research backing for it as an approach. But my own emotional responses were popping up during that first 20-minute talk in terms of when you get to the point of talking about using this approach, I think you can kind of park it as, from my opinion, it's just not ethically sound whatsoever. As an ethical standpoint, never mind the effectiveness of the research, I don't think. But when you talk about using it with a 3-year-old child, how can you possibly have exhausted the potential for non-aversive treatments and interventions for a 3-year-old child? It's unconscionable, to be honest.
Yeah.
So
I think that's a really good point. I think that I think that study in particular was the one that probably horrified me the most in terms of seeing the use of something like this with a 3-year-old. Obviously, all of the other issues apply, but not trying out any other interventions first. But that one really was pretty horrifying.
Can I ask, like Michael, something that also comes to mind is, like, I engage in self-injurious behavior, but it doesn't translate to pain to me because I have sensory processing issues. So when you say that it's hard to fade, I think that they also don't consider, for some people, this may not translate to pain either. And it may become a replacement addiction, so to speak, into sensory seeking as well. And so it serves no replacement behavior again, because either you're hurting me or either you're just replacing a dangerous behavior with another dangerous behavior, but we're not, getting any type of replacement behavior that doesn't hurt or harm us,
Yeah. So a question to all of you that I would have would be, in terms of any clinical practice that you've done, have you ever come across anybody that you've worked with who has been exposed to contingent electric shock or other kind of use of aversive forms of intervention?
Not that I know of contingent electric shock whatsoever. In terms of other aversive forms of intervention, that's the whole opening of the can of worms around where does aversive start and end. So loads of people that I would have worked with over the years would have had physical restraint used over lengthy periods of time, psychotropic medications used for lengthy periods of time, multiple medications to counter the side effects of the medications. Like it's like this, to me, this is like almost like a tip of the iceberg, black and white. How could you stand over this approach? Restriction or human rights infringement. But then it becomes a lot, there's a whole of the spectrum of restrictions on people's rights that are used on a daily basis that are less obvious to people, more culturally accepted, and may be necessary in some extent, and maybe justifiable in some extent, not contingent electric shock, but some other forms of restriction. But I think it's the next, I would like to think it's the next large growth area within positive behavior support and behavior analysis, to reduce the use of those practices through the use of positive function-based practices. So I was thinking about this in preparation for coming on, that there would have been people children, young people and adults in the services I would have worked in a few years ago, self-injuring in the region of 5,000 to 6,000 times a day. And over the course of a year and a half, 2 years, myself and other colleagues would have reduced that to near zero or zero without the use of these types of practices. But that's the response there, like the effort involved in that is massive. You have to really do everything you can to try and understand what's going on for the person. A lot of times there's pain elements involved. There might be lots of unseen, like Joy is saying, lots of unseen things that are hard to figure out, but you can work towards through collaboration with medical professionals, finding out what's actually going on for the person. That might involve multi-component plans that are necessary to get over the line, to get towards the reduction in self-injury or aggression and build the person's skills to meet their needs in other ways. And one of the things that keeps coming back to me in this is, I think from what I've read, that contingent electric shock has been used with people with self-injury predominantly in terms of the topographies that are being addressed. And a number of the people that I would have worked with anecdotally over the years with significant self-injury would have had a pain component within that. And that could be dental pain, or it could be migraines, or it could be food intolerances, and just dumbing down their efforts to communicate the fact that they're in pain and just reduce them and get rid of them rather than addressing what's causing it. It's just I'm struggling with it as a concept.
You know how you have like muscle memory? When I stem, because I also used to get shocked for stemming. So before I stem, I have something similar to like a tick, and I call it a tremor. And I think it's like a muscle memory that I get, like a tremor before. And it's a happy stem. Like it's when I get happy, but I get a tremor before that. Now, I don't have any clients that have been through it, but it was recommended for my daughter's 26. She's also autistic, and she eye gouges. And of course, my parents recommended that we do it for her. And of course, I wasn't for it, but I haven't had any clients. I'm a new BCBA. So I haven't had any clients, and I wouldn't stand by. But I think it's really important what you said about multidisciplinary. If you're not considering the person as a whole person, you need to treat the whole person. So we need to do more working with other people to be able to help monitor those internal events. Because although the function of my behavior was very important, I will tell you there was a lot of things that were probably misread when I go back and read my medical records, now that I'm able to look at them, that I'm like, this is not what was going on. Like I had a lot of internal events that were going on just due to me not being able to speak and not understanding and comprehending what was going on. And I think, and when you look at somebody and respect them as a full human being, you need to treat the full human being. We can't just treat the behavior. You have to work with other people in other disciplines to help monitor the whole aspect of everything that's going on with a person.
I think that's a really interesting point, because one of the things I think in the studies that you've included within that review, Mike, is they very much do provide some information some of the time on the behaviors, but the details about the actual person themselves in some of those studies seem to be very limited. It's why a lot of the questions that we have, we can't answer with the use of that. Are there any suggestions people would have for future research that's reporting on the interventions for challenging behavior? Because we've seen the limitations in the studies that we've looked into with regard to contingent electric shock. We've seen that we can't answer a lot of the questions because the information isn't there. What is some of the important information you would need to include if you were doing research into challenging behavior more generally?
I think social validity needs to be revisited. We don't know how to discern currently differences versus maladaptive behaviors, and I see that it's used interchangeably, like in treatment plans. And so I think it's all surrounding neurotypical behavior. And so there needs to be an opening where we consider more things that are differences versus maladaptive in order to comprehensively treat things. And that includes sensory differences. While it does come off as self-injury, and yes, it is dangerous, you need to view it as an additional input or a regulation method that needs to be remediated through a replacement behavior, not an additional punishment or anything that's harmful. So I think in part of doing this is we need to consider autistic people as people, and discern that something that just doesn't look like you doesn't automatically mean that it's a wrong. And there's adaptive behavior in those, what neurotypical people call as adaptive. Like when we don't make eye contact, that's adaptive because we have been aware that it's overstimulating to us, so we don't look, right? So that's an adaptive behavior. I don't look at you. The only thing you need to teach me is how to advocate and to say, hey, I may not be looking at you, but I'm paying attention. But instead you create a problem and additional pain by making us look at you and making the problem me not looking at you, not that I'm overstimulated. So some of those things we need to reevaluate when we're approaching interventions and consider the person as a person, you know, and really go towards nothing that's punishment based. Like I have a really hard time understanding how this is even a thing. And this is 2021, you know, like.
That's a really good question. Actually, I'll put that to the rest of the panel. What is your general impression of why is this still a thing?
I was trying to figure that out, right? And I was thinking, like, one, you'd imagine that the people that go into this line of work aren't going into the line of work to hurt people, you'd hope, right, as a start point, you know? And I suppose any organization that uses it must have an organizational culture that normalizes its use and must have a narrative around it that this is the only way to achieve that level of change, right? That must be a start point. I suppose as well for the clinicians using it, there's probably a variable ratio of reinforcement, like whereas sometimes you use it and it works straight away and it seems to reduce the behavior straight away. And therefore that means it's great and it's working. And for other people, like Mike was saying, it might take a couple of months. So this isn't, again, not acceptable, I don't think, but you can see the rationale for why somebody might think, oh, this is what works for me. I know myself with more positive approaches, I lean on what I've done before and what's worked for somebody else, and I might try that for somebody next time. So maybe the same kind of patterns on for people working in this area. And I guess the response effort from the point of view of the clinician is way lower because you can just press a button on a shock control device that delivers that shock to the person, and there's way less effort involved than doing a comprehensive functional behavior assessment, trying to consider the person as a whole and their entire learning history, the constellation of events going on around them, all the different stimuli that may be evoking and reinforcing behavior, not just for boxes of attention escape, tangible and sensory. There's a lot of work in that, there's a lot of time in that, and it was really quite interesting when Mike brought up the in the Salvi study, one of the rationale being it required too much resources to do something else, and that might not be effective. It takes time for it to be effective, and obviously at times it isn't, but that's not the rationale to not do it, I think. And also I wonder, having come from, I've worked in a number of different environments, but for a number of years in a private profit-making environment. And I wonder if there's a perverse incentive for the organizations who use this, that once you're in that environment and you're receiving contingent electric shock, that's likely to cause aggression towards the people who are delivering the shock. It's likely to cause other behaviors that are then need to be treated by the contingent shock. And the fact that you're in it means you stay in it. And if it's a private profit-making incentive, it's good news that you don't move on from the treatment program, because that's beneficial for the organization who are delivering the treatment.
That's really great.
Potentially.
Mike, do you have anything to add on the question of, have you an opinion on why is this still happening?
I think Dave's points are very good ones, and I think it's important to consider that you know, it's transactional, and so for instances, you know, within a culture of a place or institution that uses that procedure, if if it is lower response effort and there are variable times where it does result in an immediate reduction in challenging behavior, and just in the immediate, then that may persist in that place. And I think you know, to the point of that, the positive procedures, they do take some effort, and it's as you said, Dave, it's not an excuse not to do them. You know, I think that we are aware that the impact of punitive procedures and why they might occur and under what conditions they might occur, and really try to we can't, you know, go down that road and kind of fall to those same variables when we have these other technologies available to us.
Great. I'm aware that we've got a limited amount of time left, so I just want to move on to the question of basically what do we need to do next. Now, Mike, basically you and the IASSIDD have issued a policy statement, and you've called on some organizations to take, some other organizations to take action as part of that. Would you like to explain a little bit about that?
You know, I think you know, I had the opportunity to write that paper with some colleagues. The first author was actually my postdoctoral supervisor, and I know that so it was a again kind of an unfortunate experience, but appreciative of having that experience of reviewing this research with her and her colleagues. I think it's, you know, important for the field, for behavior analysis, for psychology, to acknowledge that this is, you know, an aversive technique that has adverse and unwanted side effects, and to indicate that, you know, it should no longer be used. Again, I think things have taken have moved for the positive with the ban that the FDA imposed. But having other organizations indicate that you know, this is not an okay procedure, you know, I think is the right thing to do, and I think it would be good for the field of those providing services or care to individuals with intellectual and developmental disabilities, as a sort of the message that you know, we don't support these such procedures as this.
Yeah, no, I think that would be really valuable. Dave or Joy, would you like to add anything on that about what can be done next?
I'm just thinking in terms of the training for behavior analysts and in terms of ABA programs. So I think I was fortunate that the master's program that I took part in had a major emphasis on positive behavior support and a human rights-based approach to behavior supports. But I'm not sure that all programs would have the same lean towards that necessarily. We're developing practitioners and clinicians who are going to be working in situations with significant behaviors of concern, without necessarily being exposed to this kind of spectrum of restrictive interventions that people may be recommending or maybe asking you to recommend in that scenario. And thinking about it from, I guess, from my perspective, ABA and positive behavior support specifically is based on constructing the skills the person needs to meet their needs effectively and not just reducing the behaviors of concern whatsoever. It's an empathetic approach, and it's based on relationships and building relationships with people. As part of that, like Joy's saying, if you experience this procedure or other restrictive procedures, it completely hampers the relationships you have with the people that are trying to support you, and has a knock-on effect on your relationships with other people in the future and your trust of other people. I don't know if you want to talk about that, Joy, in terms of what the kind of restrictive procedure like this, how it impacts your trust for other people who are trying to, who might be legitimately trying to help you. I don't know if you want to talk to that.
I think I want to piggyback off of, well, both of you guys, I agree with both of you, but Dave, more qualitative research that looks at the consumers, because most of us are adults now. It can really close the book on this if you just, do research that concentrates on what we say and what we report and was it beneficial. And I'm quite sure that it will say no. And that it'll reveal the harms that have been done. You shouldn't have to have therapy to undo therapy. And most of the people that I've met, because I went to a school with, all of my peers were autistic. So I know other people who have gone through this. And so we went to kindergarten on up. And I've seen, like the harm that's been done post that, so I'm quite sure if you were even to just review 100 of my peers, they would all say, no, 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 no. And to me, that would be enough because we're your consumer. We're the only quote unquote industry that doesn't really care about what the consumer thinks. They think the consumer is solely the parent, and that's not the case. Because what they don't realize is autistic people have autistic children. I have autistic children, I have autistic grandchildren. And now my autistic child is very apprehensive about ABA because she's old enough, she has her own children, she's non-vocal, she's not neurotypical passing, she's not what they expected her to be, but she's thriving in this world and they don't expect her to be a parent that's making the decision, but she is. And she's like, no, because I've seen the harm that it does. So you're gonna lose buy-in from your consumers, and so you have to think about that, even if you wanna think about it on the least ethical standpoint, which is what Dave was talking about. They just wanna make money and create more problems that are non-existent. So if you just thinking about it from the monetary standpoint, you're gonna lose money because we're not gonna buy in because it's not helping us, so you need to think about like that. And that would close the book on it, just to think about the consumers and what we are saying. This was helpful, this was not, Yeah,
nope, that makes perfect
I
sense.
I think you shouldn't have to have therapy to undo therapy sums up the entire discussion.
right.
Yeah.
Well said.
Great, that is well said. Quick piece of housekeeping for people who want to get their CEUs. The word you will need is CESS. That's capital C, capital E, capital S, capital S. One final quick question we have from Cassandra. Cassandra is asking about basically people who advocate for the use of shock being invited to conferences and participating in ABA organizations. Is the issue of basically ABA organizations effectively giving platforms to people who advocate for contingent shock an issue that should be looked at? Or is it a case of that when people are presenting research that we need to get that research out there? So basically, should organizations who are promoting contingent shock be invited to ABA conferences and the like?
I'll get Mike to say it. I've thought about this and I'm kind of on the fence because is it better to have it out in the open for people to be publicly saying what they're doing and publicly held accountable for what they're doing rather than not, or just provide the platform, give legitimacy to what's being done. And I don't know the answer to that really. I think to some extent it's better to have it out in the open that people can challenge it, because if it's happening anyway, people are seeing it, there's some oversight and people are I would presume struggling to defend it, I would think, is a valuable perspective, but then also it might be legitimizing providing a platform by being able to state, oh yes, we presented this conference, so therefore it must be an accepted part of the science. I'm kind of weighing that up, I'm not sure.
I
Okay.
don't know the answer either, but I actually have a meeting with them next week, and I'm gonna ask. You know, like, like I don't understand what's going on, and I have dedicated. I'm gonna fight for it. So I don't understand. I don't know the answer either.
Yeah.
I'll go off that as well. It's a very hard question to answer. And you know, I agree that if these things are going to be happening, having them out and being able to observe what is happening, and being able to challenge them, and with the hope that eventually, with enough challenging and critical evaluation, that an organization might come to the conclusion, once there's a sufficient number of challengings, that it may not be appropriate to be including. But it's a very difficult question to answer.
Yeah, it is a difficult question to answer, and I think there's let's say, some people are saying in the comments that sunlight is the best form of disinfectant, and that can be the case. And on the other hand, I've read documents where people have used the fact that, for example, they have published in peer-reviewed journals, or that they have gone through a peer review process, as might be the case with the conference, and they've used that as part of an argument to suggest that this shows that contingent shock is a scientific, it is scientific and legitimate. So it is a difficult thing to give a definitive answer on, but I think it is very much something that we all need to look very carefully at, and see what is the actual benefit, because I think that we've just discussed the fact that basically the use of contingent shock is so rare that the value that people who would go to a conference would get from going to a presentation on a technique that they will never ever use is pretty limited. So it's not really clear who actually benefits from these presentations being made. Any final comments from any of the panelists? Any last things that you would like to say before we wrap up?
I'd like to thank Julie for being here, to be able to provide a personal account and experience. That's invaluable for start. And then I think I'd just like to reiterate, I think it's tip of the iceberg stuff where this, we can easily get behind this and say black and white, completely unacceptable. But the psychotropic medication, the seclusion, the environmental restraints, the physical restraints, all of those things that are a lot more culturally acceptable are where we need to be getting our focus at, I think, as a field.
Thank you for having me.
Yeah, thank you. Thank you.
Brilliant. Okay, so we've had really nice feedback for all of our panelists, in particular Joy. We don't have time to go through and list out all of those positive comments for all of you, but we will share those comments with the panelists. We'll send those on to them after the event. So thanks very much to everybody who's attended today. Thanks to Alan Tennyson as well from the Munster Behaviour Analysis Forum, who's hosted this event and who's organised it. And if anybody has any feedback, you can submit that to the Munster Behaviour Analyst Forum after the event. So thank you all very much again.
Cheers. Thank you, everyone.
Thank you, everyone.
Bye.
Bye.
Are we staying or are we leaving?